Hi there, I'm Dr. Stephen Phelan. Welcome to Dental Excellence. And for today's video, I'd like to share with you a slide that shows the different putties and stents that my dental assistant will have ready for me the day that I go to prepare a case. So the day that I'm preparing a veneer case, full arch reconstruction, partial arch reconstruction, any kind of reconstruction or cosmetic case, we have a very precise system that we follow to prepare the teeth. And it's really based on a quote that I shared with you in a previous Dental Excellence video, and that is begin with the end in mind. So we begin, and this is from Stephen Covey, and so we begin our preparations with the end results in mind. So I'm using the different putties and stents and guides created from the duplicate model of the Diagnostic wax-up to guide my preparations so that I don't over-prepare the teeth. If you recall from another Dental Excellence video, I said that one of my primary philosophies is to prepare the teeth as conservatively as possible to, number one, leave as much enamel as possible to bond the final restorations to, and number two, to leave the teeth as structurally intact as possible. So I would rather my porcelain restoration or whatever restoration to break or fracture as opposed to the tooth, the underlying tooth to break or fracture. I'll take that 10 days out of 10. Because if the underlying tooth breaks or fractures, there's a good chance you're switching the case to a dental implant. But if the porcelain restoration fractures, no big deal, you replace the porcelain restoration. That's much better than extracting the tooth. So, that's always my bias. And you'll hear me say this over and over in different videos and clinical training videos and seminars and webinars, because I just think that it makes sense. So, the other thing that we talked about, or the other concept that we talked about in a previous Dental Excellence video, is that the Diagnostic wax-up is the blueprint. So that's the blueprint for the case going forward. And the way we make it the blueprint with the preparations is with preparation guides and stents. So if you look at this particular case, you can see we have the wax-up here. We have the Diagnostic wax-up that Harold Heindel has created. This is a partial rehabilitation for the lower arch. We're placing crowns on the lower molars and veneers on the lower cuspids and incisors. But the lower bicuspids were fine, for this particular case. So, and the shade was reasonable, so there was no reason for me to veneer the lower bicuspids. And, if I can, I'd rather really not veneer lower bicuspids. They're not my favorite situations to build veneers for. So we decided not to. I thought we could bleach them, and that would be fine. So if you look here, Harold has created this first putty from the Diagnostic wax-up. So he's created this putty so that he can make the duplicate model of the Diagnostic wax-up. And we want this duplicate model so that we can create the rest of the guides and putties. Because if we start creating our wax-up, our guides and putties on the Diagnostic wax-up, we end up breaking the wax-up. And you can't make vacuum-formed putty guides on a Diagnostic wax-up, so it's just unrealistic to just receive the Diagnostic wax-up back from the ceramist. We always ask on our Diagnostic wax-up communication form, we always ask for a duplicate model of the Diagnostic wax-up, and we'd like the duplicate model poured in vacuum mixed dye stone, so it's as strong and accurate as possible. So Harold does an excellent job reproducing the Diagnostic wax-up with our duplicate model, and then we make two sets of putties that go over top of the entire prepared surface of the teeth and overlap the gingival tissue. And I use these putties to vertically section them down the sagittal axis of the tooth, and this allows me to see the preparation relative to the Diagnostic wax-up, the outside surface of the Diagnostic wax-up, represented by the putty. So if I have a case where there's crowding and it's a complicated preparation three-dimensionally, I'll actually cut the putty more than just the midfacial. I'll cut it on the mesial line angle area, I'll cut it in the midfacial, and then I'll cut it again on the distal line angle area. So I'll cut it about 3 places for each tooth if it's a difficult preparation case and the arch form is not where we're going with the final restorations. If the arch form is fairly reasonable and close to where we're going with the final restorations, I'll often just cut it down the midfacial of each tooth. But we'd like 2, because if you're working on a whole arch, an entire arch, by the time you've cut the putty and gone through 3/4 of the arch, the last part is not very usable. It doesn't work very well. So you have to then go to the second putty and cut it the opposite direction. So I use 2 putties cutting in opposite directions so that I have good stability of the putty when I'm assessing the tooth preparations from a sagittal perspective. And until you've gone and done this procedure, you don't really get what I'm saying there maybe, but once you've done it, you'll understand why we like to have 2 of these putties. And you might ask yourself, well, why don't you just cut the putty that Harold made? And I'll tell you that that putty I like to keep in case I want to use it for the provisional, So sometimes I will use that putty for the provisional. So I like to keep it intact and I don't like to cut it sagittally. And then the next putty that gets created is an incisal indexing putty. And this incisal putty is actually used with the preparations at the very beginning to assess the amount of incisal reduction I need to have, or occlusal reduction, with these tooth preparations. So again, I want to begin with the end in mind. Before I even prepare the teeth, I put that incisal putty in and have a look. I also typically put in my Copyplast shell, which I'll share with you in a minute. Now, after these putties are made, my assistant takes the duplicate model back to our lab area, because typically they're actually doing the putties in our like the offshoot of our sterilization area. We've got a really big L-shaped sterilization area, and so they're typically doing the putties on the one side, which isn't the actual sterilization area, it's more the case area. And then they go, at least that's what I notice in the office because I don't make these. One assistant used to make them in the back. The other assistant who's doing it now is making them near the sink in the offshoot of the sterilization area. Now, after that, though, they have to take the model to the back of the office because that's where our lab is. And in the lab, we have our Biostar machine to really give us unbelievable accuracy with our shells. So with this Biostar machine, we have a Biostar. Some offices might use a Mini-Star, which is a great product too. It's just a smaller version of the Biostar. With that, we make 2 hard cast shells. So we make 2 of these hard cast shells because I'll use these to make the provisionals 9 times out of 10. And sometimes I don't like the provisional after I've made it in the first hard cast shell. So I'd like to have a fresh new one to make the provisional if I have to make it again. Just the other day, I was making provisionals and we selected a shade for the provisional. And quite frankly, the shade was darker than what was indicated on the label. You know, we wanted a B1. It was really closer to A1, A2. So it wasn't really accurate. For some reason, it was near the end of the cartridge, and I just don't think it was shade accurate anymore for whatever reason. And so I wanted to make another provisional. So we needed another hard cast shell because the other one it's full of old provisional material that kind of gets stuck to all the other teeth. So we like to have a fresh second one in case I want to make a second provisional. So we took a bleach shade for this case, and it was closer to A1, or B1, sorry, this particular case. I said to the patient, you know, this doesn't look close enough. It's yellower. We have the option of going slightly whiter than your natural dentition. Is that okay? And he said yes. So again, two shells are good in my case. We could always go to the putty as well. So we even have a third option. This particular case that I saw this week, I didn't actually have a diagnostic wax up completed on because it was the replacement of a central incisor crown. So I didn't really need the wax up in that case because we already had the end in mind with this model with the central incisor crown. The crown had a marginal problem old crown, but the shape was reasonable. We just shaped it a little bit on the model. So we didn't actually need a wax up. It wasn't a large case. It was a single central. So the next thing that we'll make in the back on the Biostar machine is a copyplast shell, which is a little more flexible, thinner material. And what we do is we put a series of holes in the copyplast shell with a small diamond or carbide burr in a high-speed handpiece. We'll put a series of holes that will allow me to map out the surface of the preparation. So it gives me the topography of the preparation, and we'll often put this shell in first at the beginning of the preparation appointment as well, because this one and the incisal putty give me a lot of information before I even put the burr on the teeth. The vertically sectioned putty, we pretty much destroy it to see the preparations. So I like to use that near the end. Once I think I'm right there, I've nailed the preparations, I use that vertically sectioned putty as the final check to make sure that my preparations are excellent. And sometimes I'll see, oh, I didn't prepare the incisal third enough. The teeth might have the restorations, the final restorations might be sticking out a little bit, which is something we don't like and something patients don't like. So they're really helpful, those incisal putties, or sorry, the full coverage putty, when I section it sagittally, it's really helpful to see especially that incisal third of your preparations, which is often under-reduced. We don't want to over-reduce cases, but we certainly don't want to under-reduce the incisal third and have issues with the incisal tooth position, because that's critical for the aesthetics of our cases. So, those are the putties and shells that we have made, and I'll walk into the operatory and those are all there every time when I go to prep a case, if it's a case bigger than a posterior crown. Even that single central crown that I did this week, I had all of those except the wax up because we didn't need it. We just had the duplicate model of the wax up was in fact the study model of the case. We just reshaped the incisal edge a little bit to improve it. And so that's what we have. I expect that every time I go in to prepare a case, and that my assistants deliver that, because that's what we need to provide excellence and precision for our cases. And we actually filmed the video on how we made these for my occlusion design members. So my assistant and I filmed this, I edited it down, it's about a half an hour, her making all of these putties and stents and indexes and preparing them for a case. So on occlusiondesign.com, if you're one of the members, you can basically look at this. It's in Module 5. So it's in Module 5 of Occlusion Design. It's called Fabrication or Fabricating Preparation Putties and Stents. And this is designed for you and your assistant to look at together, and then for your assistant to review to make these for you. So thank you again for joining me on these videos. And I just want to remind you, you can do this kind of dentistry. Your assistant can get all of this ready for you. You just have to help them see what is needed, help them understand how to make these putties and stents, and then it can all be ready for you each and every time you go in to prepare a case. So you can do this kind of dentistry, and as I've said, beautiful dentistry with precise fit and occlusion is not just for the gurus.